I'm happy to be here to share my thoughts about nutrition support in short bowel and in intestinal fistulas. I want to start off with a case presentation, an elective colon surgery, 50-year-old obese male at a major university hospital. The dietitian contacted the primary care physician and internist to convey their concerns of significant weight loss. So why can't we postpone the surgery for a while, being elective? The advice was disregarded. Post-operatively, the nasogastric tube suction was maintained for 3 to 4 days because someone said there are no bowel sounds, therefore how can we treat the patient? Clear liquids were started on post-op day number 5 for 2 more days. Why clear liquids? I don't know. Enteral formulas started later for 2 more days but limited to only 500 cc's per day. A major complication occurred on post-op day number 9. Now friends, I guarantee and I emphasize that I was not the surgeon on this case. What happened to this patient? This was an elective abdominal operation for a colon resection. And here's a patient with a wound dehiscence. On the upper panel, you can see small bowel protruding out. And on better exposure, you can actually see the mucosa of the ileum. This is a small bowel fistula. Now, whose fault is it? Is it the dietitian's fault, surgeons, internists, patients? So I'm going to focus a little bit too on how dietitians and clinical nutritionists can prevent complications like this from happening. Small bowel fistula and to some extent short bowel syndrome too, but not all the cases in short bowel syndrome. Now here's another patient in whom there was massive injury to the small bowel. Multiple anastomoses were done and the patient was not fed adequately earlier, so had multiple tubes put in, as you can see in the upper panel on the right side, vacuum assisted closure. Finally, the appearance was like this. Now, when somebody comes for an elective operation, it doesn't mean that complications like this won't occur in the best of hands, but at least to a great extent, complications like this can be prevented if we take preventive action, which actually starts off with the patient even coming to the hospital prior evaluation by the dietitian. So what went wrong in my patient, not my patient, but the patient which I presented earlier? What went wrong? The advice of the dietitian was ignored. It wasn't appreciated by several people that an obese patient may be fat but not fit. Sarcopenia can occur in obesity. Preoperative supplements were not even considered, and in 2024 it is medical malpractice for anyone to go to elective surgery, especially GI surgery, without preoperative nutrition counseling and nutrition therapy. It has spread to orthopedics and to cardiac surgery too, when there is absolutely nothing to do with the bowel. But in this patient, it wasn't done. Enteral feeding was not started immediately post-op because after all the patient had only small bowel injury that was sutured easily, and also it was just a colon anastomosis that was planned. It wasn't advanced rapidly, just 500 cc's a day for reasons that are totally unclear. And there was no system in place. The poor dietitian had no recourse to go and complain to someone that their advice is not being followed. Now you contrast that to this child in middle of war zone in the Middle East, where the child grabbed what he thought was a toy, but the toy actually ended up to be a hand grenade, and the hand grenade blew up his abdominal wall. And after multiple operations, like you can see here, somehow the abdominal wall was reconstructed. But why am I showing you this slide? The young surgeon, who was not only a fully qualified surgeon, sent an email to his supervising surgeon in Washington I was able to manually place a soft-bore feeding tube across the pylorus into the jejunum and initiated enteral feeding immediately. The patient did well. Now, if this can be done in a war zone, in a tent operating theater, why are we not doing it in a major university teaching hospital? And it is for that reason we have to prevent complications like this from occurring, because patients do not die in a hospital because of a major physician error. It occurs because the hospital allowed a complication like this to occur. This doesn't happen in the airline or automobile industry, where there are checks and balances, and we make sure that every box is checked before the automobile is released into the market, or before the flight is allowed to take off from the from the tarmac. Even a mechanic who sees an oil on the ground can prevent a senior 747 pilot from taking off on a flight. Likewise, dietitians should also be empowered to say by hospital policy that this patient for an elective procedure is not a suitable candidate. Now, of course, the surgeon can override it, but the overriding reason should be documented in the patient's medical records. So we talk about a gap between evidence and between practice. This is not a gap, this is a chasm. It takes 17 years for practice patterns to change, and only 1 out of every 5 evidence-based interventions make it to clinical practice. Now let's look at some delays in implementation of nutrition therapy, as you saw in the earlier slide. Bowel sounds are not involved in decisions to initiate feeding. Anastomosis is not a contraindication for enteral nutrition. Gastric residual volumes are no need to be measured routinely. In fact, routine nasogastric tubes are not needed. And when you aspirate something from the stomach, you've got to put it back into the stomach, like I will explain to you in a little bit, into the stomach or into the jejunum directly. And don't use parenteral nutrition when it is not really needed. We have to remember that micronutrients are very important. If they're not provided adequately, and if they are all thrown away with the GI aspirates, as we will learn in a few minutes, then the complication rate also increases. So we now talk about preoperative oral nutrition supplements, which is not something very new. Enteral nutrition support decreases wound complications, length of stay, duration of the ventilator, anastomotic leaks, and postoperative fistulas if given 7 to 10 days prior to surgery. Look at the date, my friends. It is 2001, 24 years ago. And the same thing was re-emphasized in 2014, 10 years ago, to say that when oral nutrition supplements are used for preoperative optimization, you don't always need the so-called immune formulas. We don't even know exactly what it means. Any scientific formula can be used. And yet, in spite of information that is available for 20 years, the patient that I presented did not have preoperative oral nutrition supplements. And I would urge all of you to make sure that you change the system in your hospital, that no elective surgery should be done without a nutritionist saying, okay. Now, a nutritionist approval is as important as cardiology or anesthesiology clearance, and I've been successful in getting this going in several hospitals. This is not only a nutrition assessment, but this is a physiologic assessment. We correct deficiencies of electrolytes. Glucose levels are normalized. This is the time to talk to patients about potential complications and how can we feed you if in case a complication occurs. The patient is given for 7 to 10 days an oral nutrition supplement of a scientific formula, just 500 cc's a day, split over several feedings in a day. And the complication rate has been shown to be low. This study is amazing because it concentrates on preoperative oral nutrition, not only with scientific formulas, but other kinds of oral nutrition, focused on low and middle income countries, especially in GI cancers. This is a study that is doable in India. I would urge all of you, if you are interested in doing a survey of this, it should be actually conducted in our country. And it is quite possible that we can spread the word around that in 2024, every patient in any hospital should have a nutrition evaluation prior to GI surgery so that fistulas and other complications do not occur. To understand this better, I'm going to spend a few minutes on anatomical aspects and on physiological aspects. In anatomy, we know that the small bowel is divided into the duodenum, the jejunum as shown in the blue color here, and the ileum. And the ileum of course goes into the colon. I would say that the most important parts of this are the duodenum and the jejunum. Combined with the jejunum and the ileum, the length is about 600 centimeters. Combining the jejunum and the ileum. And if you have less than 200 centimeters, this is called a short bowel. The duodenum is shortest, only 25 centimeters, but a lot of absorption occurs in the duodenum. So keep in mind, the combined length of the jejunum and the ileum is about 600 centimeters. Anything less than 200 is a short bowel. But in the ileum itself, if you look at it under an electron microscope, from view A is just what you see in an endoscope, B is magnified, and then finally, if you look at a scanning electron microscope in biopsy specimens, you can see villi and microvilli. Therefore, if you take the small bowel as a cylinder, it is only a length of about 3,300 square centimeters. But if you take the villi and the microvilli, the absorptive surface of the small bowel is something like a tennis court, 2 million square centimeters. The small bowel villus looks like this. However, when you don't feed the patient, it atrophies, and intact bacteria and fungal elements and also toxins, antigens go through the bowel wall, producing a systemic inflammatory response syndrome. So early feeding to prevent atrophy is extremely important. When the next couple of slides are not to confuse you, but just to tell you that there are various ways by which, if the stomach is resected, for example in this slide the purplish area, then there are various ways in which it is reconnected. And when you reconnect the small bowel, as you can see in the upper right hand side, then there are several anastomosis, and it is possible to get complications because of leakage from this. That is how fistulas occur. A fistula is nothing but a connection between the bowel and the outside, either the atmosphere or the skin level of the fascia. So if you are taking out the pancreas, for example, the shaded areas are actually removed. You'll find that there are many anastomosis between the bile duct to the intestines and from the stomach to the intestine. So suffice it to say, these are all precarious anastomosis, and they can actually leak, producing a fistula. But what is of more importance to us to understand short bowel is actually the vascular supply of the ileum. You can get a blood clot in the superior mesenteric artery, and that essentially it produces gangrene of the right side of the colon and the small bowel, as you can see in the right side panel here, leaving behind only the jejunum, and that produces what is called a short bowel syndrome. The ischemic bowel looks like this instead of a clear, nice pink color with peristalsis and with pulsation in the arteries. This has to be obviously resected. Now, coming to a few words about physiology, understand that we produce about 1 liter of saliva every day, rich in potassium. So if you're throwing away that saliva, almost 20 milliequivalents of potassium get thrown away every day. Our requirement is about 60 to 80 milliequivalents. If you combine the saliva and the gastric juice and pancreatic juice, everything put together, you have about 6 liters of fluid flux in the small bowel. To the 6 liters, we are asking to have the patient given about 500 cc's of a scientific enteral formula. When we say post-operative feeding, we don't mean a big bowl of biryani and 1 tandoori chicken every day. We just are talking about 500-600 cc's of a feeding given at a very slow rate. But Although I think a lot about the electrolyte secretions of GI component of GI secretions and the need for us to reinstill gastric aspirate to prevent complications from occurring. More than that, the saliva has growth factors, and the growth factors in saliva, like the nerve growth factor, epidermal growth factor, won the Nobel Prize in 1986. It contains fibroblastic growth factor, various kinds of growth factors which are beneficial to heal mucosal defects. That is why animals lick their wounds. And we know that when we go to a dentist and have a major procedure done on our mouth and the gums heal very, very rapidly because of the growth factors in the saliva. I worry a lot about micronutrient losses in GI aspirate, zinc, copper, manganese, selenium. Many vitamins are lost in nasogastric aspirates, and therefore having an NG tube routinely and throwing away the NG tube aspirate into the garbage is also not at all good, because the stomach and the duodenum, as listed on the slide, are the sites of the major absorption of the micronutrients, copper, zinc, manganese, various vitamins, and therefore we should make use of the aspirate and a functioning duodenum and the jejunum to prevent complications such as fistulas from occurring. Having said that, under the best of circumstances, fistulas do occur. It may occur in the proximal ileum of the jejunum, distal ileum, the right-sided colon or the left side of the colon, and anytime the output is more than 500 cc's, we call it a high output fistula. We would prefer, the more distal the fistula is, the easier it is for us to manage. If it is on the left side of the colon, then it is almost like a colostomy. Literally, the patient can eat anything they like when the anastomosis, when the patient is recovered from surgery. However, when you have a distal ileal fistula, then it is almost the same like an ileostomy. Or the right-sided cecal fistula is almost like an ileostomy, because the effluent coming to that area is actually more liquid. Now, when you have necrosis of the small bowel, as you saw earlier, the surgeon may elect to anastomose the jejunum to the ileum, and this is called a jejuno-ileal anastomosis. Now, there are other times when the jejunum is anastomosed to the colon, as you can see here. All the shaded areas are the ones that are removed. Sometimes even that cannot be done, and you have an end jejunostomy. Here, obviously, the patient on the right side extreme will need parenteral nutrition for a long, long time. The patient in the middle and on the left side needs parenteral nutrition for a short while, but gradually the bowel will adapt itself and you can get away with it, provided, however, a fistula does not occur. Even if the abdomen is open, you can safely give the patient parenteral nutrition, as shown clearly in these references. Open abdomen means the skin is not closed. We prefer intrajejunal feeding in these patients, but intragastric feeding is also quite acceptable. Now, this special issue of nutrition in clinical practice a couple of years ago deals only with short bowel syndrome, and I will urge you to please obtain a copy of this, or if you write to me, I'll send you some of the interesting papers from this journal. Now, we'll divide into various categories of short bowel or fistula. What about oral or enteral feeding in short bowel within ileostomy? In other words, the patient has less than 200 centimeters or maybe 300 centimeters. When the output is more than 1800 to 2000 cc's, we call it a high output fistula. These patients will need intravenous fluids. But when the patient is thirsty and they drink plain water, actually what happens is the output keeps increasing. So we should be clear to emphasize to the patient that the sensation of thirst, or in a patient who is intubated who cannot communicate, the excess water, excess fluid should be neutralized by giving the patient more oral rehydrating solutions like powders available for pediatric use. Don't use sports drinks because they increase the output. So pure water should be avoided or at least minimized, and the oral intake should be of rehydrating solutions or powders, and here is the reference from up to date. Now, if the patient can eat, there is absolutely no reason to restrict oral intake, and this is a paper I wrote some years ago. I hope you like the title. Special post-operative diets are irrational, obsolete, and imprudent. For example, the patient wants a little bit more salt. There is absolutely no reason to restrict salt in a post-operative patient who wants to eat more, and we want them to eat more. Nothing is also more laughable than cardiac surgeons wanting a patient to be on a low-fat, low-cholesterol diet immediately post-op, when the effect of dietary modifications take 20 to 30 years to actually manifest themselves. Patient wants an omelette and wants a lot of butter with masala dosa. Give it to the patient. Nothing is going to happen. Similarly, caffeine has absolutely nothing to do with postoperative arrhythmias. Anyway, if the patient can eat properly, give the patient whatever they want. Now, we should also kind of understand that fiber is sometimes used in ileostomy. Now, fiber, as you all know, is soluble or insoluble. Soluble fibers do not gelatinize and they do not block feeding tubes. Examples are guar gum, acacia gum, pectin. Inulin, fructose oligosaccharides are also soluble fibers. They don't gelatinize. The resistant maltodextrins, several available in the market, are also good soluble fibers. Less soluble are the gelatinous ones, which can block feeding tubes like psyllium and esophageal. Now these are fermented to short-chain fatty acids. And the short-chain fatty acids are the fermentation products of fiber. Fibers are prebiotic, but the colon bacteria, which are probiotics. They are acetoacetate, butyrate, and propionate. Butyrate seems to be the most important. And the amount of short-chain fatty acids that emanate from the fiber can actually produce 2 to 2.5 kilocalories per gram. But remember, this is useful only when the colon is intact. Insoluble fibers are the cellulose and lignans. Soy polysaccharide contains both. And they produce bulk in the stool. They are not fermentable fibers. Many of the commercially available fibers have a little bit of both. But the soluble fibers are the ones we really need. So we'll talk about fiber in ileostomy and short bowel. Very common question that dietitians get is, how much fiber should we give? When you have more than 1.5 liters of an ileostomy output, this is called high output. When soluble fibers like gel forming fiber supplement with psyllium husk are used, they slow the transit time. They absorb water and they follow gel-like consistency. But remember, in an ileostomy and a short bowel, there is no colon. Insoluble fibers, on the other hand, have bulk forming laxative and they increase the transit time and they use constipation. Therefore, in an ileostomy patient with short bowel, you have to change what kind of fiber you give, whether it is a liquid effluent or whether it is semi-solid effluent. Depending upon that, you can advise the kind of fiber in the diet. And you gradually increase the dosage, and it's only by trial and error. Various charts are available for dietitians showing which food group has which kind of fiber, which is beneficial to the patient. But remember, too much fiber can cause a bowel obstruction. Now let's say that a patient has a short bowel but has an intact colon and an ileocolic anastomosis. Here, for example, the right side and the bowel is removed and the ileum is anastomosed to the colon. That's very good because so much of colon is available for us to use. And it is available because the fiber gets fermented to short-chain fatty acids, and the low pH in the bowel, in the colon, inhibits the growth of pathogenic bacteria. Better bacteria, the more suitable bacteria grow, dysbiosis is cut down, and the short-chain fatty acid is used as a fuel for the large bowel, and also what is absorbed will help for small bowel by the colonocytes absorbing more water and by absorbing sodium. So the fiber, the soluble fiber with the colon is extremely beneficial. Now, if you have a person with an intact colon, does fiber always decrease diarrhea? The answer is very no. The effect of soluble fiber is osmotic and non-gelatinous. So the logic is it may actually make the diarrhea worse. You know that fiber is actually given for constipation. But at the same time, it is counterbalanced by the effect on the colon, mucosal function, the correction of cut dysbiosis, and the effects are variable. So you have to try for every patient. In the critical care patient, fiber is used not for constipation alone, but fiber is used as a treatment modality for diarrhea. But also remember, I have to tell you, 95% of the reason why patients on enteral feeding get diarrhea is not the enteral feeding. It is some other cause like medications or bacterial contamination or using kitchen prepared blenderized diets with a lot of bacterial contamination. It's only the small number of patients where the cause is enteral feeding. Only there you would think of using fiber. Now let me look at another patient here. 20-year-old patient with short bowel had abdominal pain. The patient was pregnant. It was misdiagnosed as labor pain, and after 3-4 days, the surgeon in another town, again I wasn't the surgeon on this, found there was torsion of the small bowel with necrosis, massive resection of the ileum, and in this patient, the surgeon decided to anastomose the ileum to the colon. The patient had only 200 centimeters, and now this happened way back in 1980, and I just got back from the US on a trip. I hadn't even moved here permanently. And this was one of the first patients I managed on parenteral nutrition in India in late 1990s, early 1990s. And I, with the help of my dietitians, used to mix the macronutrients, the amino acids, the dextrose, the fat, the trace elements, and the vitamins, and then give it to the patient. By a judicious combination of oral, enteral, and parenteral nutrition, over the next 3 months, TPN was tapered up. The patient was on TPN, but yet was taking something by mouth. On some days, we could not get trace element intravenous, so we gave it orally in the form of tablets that were available even then. And the patient is doing well even now with only 20 centimeters of ileum, and the patient is now 25 years of age. Now, that 20 centimeters of ileum, or proximal jejunum, would have now probably hypertrophied and is actually doing the function of about 400 centimeters. And except for small frequent stools, the patient is doing very well even now. Now, let us come to another major problem, small bowel fistulas. The first thing we need to do with fistula is to localize the fistula, which dietitians cannot do. It is done by the surgeons and by the gastroenterologists. And there should be adequate suctioning of the drainage, because the activated enzyme in the fistula drainage doesn't know whether it is dealing with food taken by mouth or whether it is the muscle or the fascia or the skin of the patient. Therefore, skin necrosis can occur. In nutrition support, remember, guidelines will say that a regular oral standard polymeric formula is absolutely fine. In selected cases, you may want to use a semi-elemental peptide-based formula. That is also all right. But in the majority of instances, an oral standard polymeric formula, which is cheaper, can be used. Remember, it's a scientific formula, not one of the hundreds of bogus products that are available in our country. And then, by judicious combination of very specialists like interventional radiologists and osteotherapists and surgery, the fistula drainage is actually controlled. But what we do as nutritionists, whatever drainage is coming down out of the enteral tube, we try to put it back into the distal lumen of the fistula. Now, we have to look carefully at medications like octreotide, for example, that will decrease GI secretions but also cause either hyper or hypoglycemia. Proton pump inhibitors will cause magnesium deficiency. So these are things that dietitians will have to learn about drug-nutrient interaction. And volume-based feeding comes into the picture right now, because patients cannot be given an order saying 1500 cc's over 24 hours. No, I'm sorry, cannot be given an order saying 75 cc's per hour, 100 cc's per hour. The order is written as 1500 cc's over 24 hours. So if the feeding is stopped for any reason, then the nurse is empowered to increase the rate. and it is continuous feeding. After the continuous feeding, you may want to switch. You may want to switch it to an intermittent schedule. And parenteral nutrition is used. It is either used as never to be used parenteral nutrition when oral nutrition is supplement. Don't use the word supplemental parenteral nutrition. No, don't use the word partial parenteral nutrition. Always use the word supplemental parenteral nutrition. Now, when you use parenteral nutrition in short bowel, please understand, you must ask yourself, is it really indicated? Have we consulted with a physician who is knowledgeable enough in using nutrition support so that everything has been done to optimize enteral feeding? What is the source of payment? If the patient is paying for it, obviously it becomes more of a difficulty for us. It is a real pity that insurance companies will pay for 4,000 rupees worth of parenteral nutrition but not 500 rupees of an enteral formula. Here is one of my patients with an extensive injury to the pancreas, the duodenum and the ileum. And this was treated by a duodenal exclusion where the pylorus is closed shut. Gastrostomy tube. The orange is a retrograde jejunostomy tube and the red is a feeding jejunostomy. Here everything was aspirated from the patient and about 1.5 liters of fluid was put back into the jejunostomy and the patient made rapid recovery without a drop of parenteral nutrition. Folks will always ask, how much of calories and protein should we give? To make it easy for you, the rule of thumb is you go less. 12 to 25 calories, 12 to 15 calories per kilogram of ideal body weight for the first few days and then gradually increase. Do not use predictive formulas. When protein intake is met, the amount of calories you give a patient is not of that great importance. And while you gradually increase the calories, the protein intake is also gradually increased, as you can see in the slide, from 0.8 to 1.2 grams. But remember, an important component of nutrition therapy is to prevent refeeding syndrome. And I would ask you to get this textbook of critical care nutrition published by the Indian Society for Parenteral and Enteral Nutrition, ISPEN, where I have a chapter on refeeding syndrome, emphasizing the fact you look at it in an algorithmic way. Avoid refeeding syndrome. Give less calories, all the more important with short bowel syndrome, and then gradually keep increasing. One of the things we emphasize here is that all critically ill patients get 100 to 300 milligrams of IV or oral thiamine for the first 3 to 4 days. So micronutrient supplementation becomes very important because the major micronutrients are absorbed in the jejunum and in the duodenum. And if you bypass the duodenum and the jejunum, or if there is a loss of these effluents from these sites, then you lose micronutrients. And all the more reason why you have to give it back to the patient. When you use parenteral nutrition, this international consensus clearly stated that since clinicians should be sensitized regarding the role of micronutrients, anytime you use parenteral nutrition, micronutrients must be included. If enteral feeding is used, if 1500 cc's of an enteral formula is used, then you will be providing enough bioavailable form of micronutrients to patients, provided the formula is from a reputable company. Now I'm coming to the end of my talk to tell you that teamwork is extremely important. And there is an evolving role of the critical care dietitian. So nutrition support is supervised by dietitians and not necessarily physicians. It's a crucial component of medical care. And in an editorial that I wrote recently, we have said that the dietitian is the most knowledgeable member of the interprofessional nutrition support team. It is they who know how many calories, how much of protein, how many micronutrients to give a patient. And when a teamwork is used, as in this study, on patients, surgical patients with trauma, you will find that enteral feeding is used more effectively. Calorie goal is used more frequently, is reached more frequently. I'm giving you my email so that you can communicate with me, and also a video of this talk that I gave you with some modifications will be available on the YouTube channel of ISPEN at ispen.org.in. So please do access it in a couple of days and look at it. Thank you very much.